sizes. Now, the French are in the spotlight with this question, Jean-Pierre, because you've had, you know, the UK 10-year results, we've got the Dutch 5-year results, we've had OVA with 2 results, and ACE came here, billed as giving some data, and the question is there any chance that we can hear something from these French who've been going on about the ACE study for the last 10 years? Any chance to hear from the French study some results?
Well, let me ask Roger something. How long will your meeting carry on? Because I can be invited every year to speak about nothing for 10 years.
Perhaps if you gave them in rapid French, it would be acceptable, because no one would understand them.
To answer your question, tell me what the French for bullshit is.
Oh, you will read it soon.
Yeah. So that throws some light. So, but Jean-Pierre, when do you expect to have the data?
Well, we sent the paper 10 days ago to the Lancet. So.
Well, so in about 3 or 4 years then. So 3 or 4 years for the peer review process. Maybe 2013 then. Okay. No, on a serious, so it's imminent then, publication. Okay. Any questions from the audience?
Yeah. Oh.
Yeah.
I'm interested to know the arguments about crossover and everything else aside. The arguments about crossover and so on aside. In all the aneurysm trials that we see, the mortality is attritional in all the groups. And in fact, if you have an endovascular aneurysm repair and you're considered fit, at 5 years your mortality is probably worse than if you had a colorectal cancer that was Duke's A or B, or you had a breast cancer or something like that. So what are all the groups doing about risk factor management and actually looking after all these other unknowns or knowns that are killing these patients in the 10 years after we repair their aneurysms?
I think Frank gladly answered that question for you, didn't he? And it comes back to what you're doing with the preoperative workup of these patients. Because I think what you're trying to do is to affect their longevity. And if you have the patient on triple therapy, which at the moment is antiplatelet agents, statins, beta blockers, plus minus ACE inhibitors, then they're on maximum medical therapy. What difference does it make whether you investigate their heart with coronary angiography? Probably none whatsoever. And it comes back to the preoperative investigation of these patients, because if you give them an epidural or local anesthetic, you convert a major procedure into a relatively minor procedure.
Yeah, sure, and I appreciate that point, but I think what's clear from a lot of the trials is that unless you're actively monitoring people, they're not really taking it. So we don't really know how many of these patients are really getting robust medical follow-up, and I think that may impact on why so many people die.
You've got some data from the carotid trials, haven't you? The total number of patients who set off on statins, who are still on statins by 1 year, is not what you and I think it ought to be. And it comes back to reinforcement of that, probably in primary care, because we don't follow our patients up that regularly.
But there are, in addition to those drug therapy issues, there are lifestyle issues, both smoking and possibly even, it's been suggested, exercise. But we really don't know what effects those have. But there are issues other than just simply drug therapy, which are not dealt with in a surgical or even radiological or endovascular practice.
Yeah, our aneurysm patients are a group of older smokers, and because of that, many of them have atherosclerosis, and if they do, it should be treated as such. I personally don't consider them the same thing, aneurysm disease and atherosclerosis, and there's a number of reasons I think they're different, the distinction regarding diabetes being one of the most obvious. And there's very little other than smoking cessation and perhaps exercise that we can cite to specifically treat aneurysm disease. Now, if they have atherosclerosis, they should certainly be treated appropriately for atherosclerosis, but I don't really blend the two. And I think one of the ways this comes up is, are statins currently a treatment for aneurysm disease? And if they are, then you can't study it. I mean, if we think that that's part of atherosclerosis, but if we don't, then it's reasonable to study statins to see if it slows aneurysm enlargement, which is one of the drugs that we have some reason to think might be useful. But because there's this belief that it's atherosclerosis, it's very difficult to get that kind of trial started.
Louise, you...
Hi, can I just say, often these discussions end up concentrating on cardiac and cardiovascular morbidities, etc. And yet, two much more strongly predictive factors of operative mortality are renal and respiratory function. And they seem to be often downplayed, and I never quite understand why that is, because I'm not a clinician. There was one lovely study, a chest physiotherapy trial, where they randomized patients to get chest physiotherapy prior to their vascular surgery, and their operative mortality was massively reduced and significantly reduced, and all that sort of